Hello. So our fourth part start from the intracranial hemorrhages. It has different subsections like epidural hematoma, rupture of middle meningeal artery. Hmm, yes, we change the color. Yes, rupture of middle meningeal artery, which is a branch of maxillary artery, often secondary to the skull fracture. Yes, it is secondary to the skull fracture and involving the pterion, the thinnest part of the lateral skull, which has the middle meningeal artery underlying, and might present with the transient loss of consciousness, recovery, lucid interval, rapid deterioration due to hematoma expansion, scalp hematoma. This is the scalp hematoma showing in this picture, and then rapid intracranial expansion arrows in the B. This is the rapid intracranial extension of the blood under systemic arterial pressure. Then the transtentorial herniation and cranial nerve 3 palsy. CT shows biconvex lentiform hyperdense blood collection not crossing the suture lines. So this is the epidural hematoma, which is due to the rupture of middle meningeal artery. It is secondary to the fracture of skull. Most important part of the skull which is involved is pterion, might present with the transient loss of consciousness. This is lucid interval and rapid deterioration due to hematoma expansion. This is scalp hematoma and rapid intracranial expansion under systemic arterial pressure, and to diagnose it we should do CT scan which shows biconvex lentiform lesion. So subdural hematoma, rupture of bridging veins, can be acute, traumatic, high energy impact, hyperdense on CT. Or chronic associated with mild trauma, cerebral atrophy, increased age, and chronic alcoholic overuse. Hypodense on CT, also seen in shaken babies. So when it is acute, which is a result of traumatic or high energy impact, then it is hyperdense. And when it is chronic as a result of cerebral palsy, increased age, chronic alcohol use, then it shows hypodense on CT. Also seen in shaken babies. So this is also an important point. There is crescent shaped hemorrhage, red arrows in C and then D. It crosses the suture line and can cause midline shift, finding of acute on chronic hemorrhage, blue arrows. The next thing is subarachnoid hemorrhage, bleeding due to trauma or rupture of an aneurysm, such as a saccular aneurysm. It is also aneurysm is also called saccular aneurysm, or arteriovenous malformation. Rapid time course. Patient complains of worst headache of my life. Yes. Bloody or yellow xanthochromia on lumbar puncture. Vasospasm can occur due to blood breakdown or rebleed 3 to 10 days after hemorrhage. When there is vasospasm, we have the headache. So to prevent this, we give calcium channel blocker nimodipine used to prevent or reduce the vasospasm. It increases the risk of developing communicating or obstructive hydrocephalus. Yes, it is also an important note. Intraparenchymal hemorrhage, very important. So let us suppose if we are sitting in emergency in a hospital and a patient comes to you and the attendant say that the patient had hypertension, and after that he had gradual loss of power on single side or multiple sides of the body, and you have a CT scan of the patient and you see this type of lesion, then most probably it is intraparenchymal hemorrhage, which is due to the hemorrhage in the lenticulostriate vessels. So let us read the text. Most commonly caused by systemic hypertension. Yes, important, systemic hypertension. Also seen with the amyloid angiopathy, recurrent lobar hemorrhagic stroke in adults, arteriovenous malformation, vasculitis, neoplasm. May be secondary to reperfusion injury in the ischemic stroke. It is a hypertensive hemorrhage. Charcot-Bouchard aneurysm most often occur in putamen globus pallidus of the basal ganglia, which shows the lenticulostriate vessels followed by the internal capsule, thalamus, pons, and cerebellum. So, in this intraparenchymal hemorrhage, the thing to remember is this is hypertensive hemorrhage, also called Charcot-Bouchard microaneurysm, most often occur in putamen globus pallidus of basal ganglia, lenticulostriate vessels, followed by internal capsule, thalamus, pons, and cerebellum. So, what is next? Next is central post-stroke pain. This is the pain which we feel after having stroke. It is neuropathic pain due to thalamic lesions, initial paresthesia followed by in week to months by allodynia. What is allodynia? It is ordinarily painless stimuli which causes pain. For example, we have a stimulus which does not cause pain to a normal person, but if we give this stimulus to a person who is having stroke and is having this kind of pain, it will cause very severe pain to that patient. And dysesthesia, altered sensation on the contralateral side, occurs in 10% of patients with stroke. Phantom limb pain, sensation of pain in a limb that is no longer present, common after amputation. Yes, I have seen this patient. Associated with recognition of primary spectrosensory cortex characterized by burning, aching, or electric shock like pain. Diffuse axonal injury, traumatic shearing of white matter tract during the rapid acceleration or deceleration of the brain, e.g., motor vehicle accident. Usually result in devastating neurologic injury, often causing coma or persistent vegetative state. MRI shows multiple lesion punctate hemorrhage involving white matter tracts. Let us see it again. This is a traumatic shearing of white matter tract during rapid acceleration or deceleration of the brain. Motor vehicle accident. Yes, we have this kind of injury. Back and forth movement of brain in the skull cavity usually result in devastating neuronal injury. often causing coma or persistent vegetative state. MRI shows multiple lesions, punctate hemorrhages involving white matter tracts. Okay. Aphasia. So, what is aphasia? Aphasia is higher order language deficit, which is inability to understand, produce, use language appropriately, caused by pathology in dominant cerebral hemisphere, usually left, which is left. So normally we have the right dominant side of our body, which is controlled by the left hemisphere. So the left hemisphere is dominant hemisphere. Dysarthria, it also occurs in dysarthria, which is we are unable to make words, motor inability to produce speech, movement deficit. So what are its type? First type is Broca aphasia, which is expressive aphasia. Expressive mean we are unable to express our words to someone, our feelings to someone. Broca area is inferior frontal gyrus. This is the location of Broca of the frontal lobe associated with defective language production. Yes, it is associated with defective language production. Patient appear frustrated, insight intact. Insight mean patient can understand what he is listening or what he is having a question, but he is unable to make an answer or answer the question. So Wernicke aphasia, it is receptive aphasia, mean we are unable to receive stimulus, verbal stimulus. We are unable to receive. Wernicke area in superior, it is located in the superior temporal gyrus of the temporal lobe, associated with impaired language comprehension. Patient do not have insight. Wernicke is a word salad and makes no sense. Yes, as this sentence is making no sense to me, patient with Wernicke area when they speak, they make no sense of what they are speaking. Conduction. Conduction aphasia can be caused by damage to arcuate fasciculus. And global aphasia, Broca and Wernicke are affected both. Yes. So, next page. So now we see what is aneurysm. It is an abnormal dilatation of an artery due to weakening of vessel walls. Okay, this is some kind of definition. What is saccular aneurysm, also called berry aneurysm? We know berry aneurysm from a disease which is subarachnoid hemorrhage. Yes, occurs in bifurcation at the bifurcation circle of Willis. Most common site is junction of anterior communicating and anterior cerebral artery associated with autosomal dominant polycystic kidney disease, Ehlers-Danlos syndrome. Other risk factors include advanced age, hypertension, tobacco smoking. Okay, first it is at the junction of anterior communicating and anterior cerebral artery. It is associated with autosomal dominant polycystic kidney disease, Ehlers-Danlos syndrome, and associated risks are advanced age, hypertension, and tobacco smoking. So clinically silent until rupture occurs. Most common complication is subarachnoid hemorrhage and worst headache of my life, as we have discussed previously, or thunderclap headache. There is focal neurological deficit, can also cause symptoms via direct compression of surrounding structures by growing aneurysm. If there is anterior communicating artery compression, we would have bitemporal hemianopia, compression of optic chiasm, visual acuity deficit. If there is rupture, we would have ischemia in the anterior cerebral artery distribution, resulting in contralateral lateral lower extremity hemisphere hemiparesis and sensory deficit. Middle cerebral artery rupture. Ischemia in the middle cerebral artery distribution, which will result in contralateral upper extremity and lower facial hemisphere hemiparesis. Sensory deficit would also occur. Posterior communicating artery, its compression would result in ipsilateral cranial nerve 3 palsy, which would result in mydriasis. Blown pupil may also see ptosis, down and out eye. As we know that extrinsic muscles of eyes, all extrinsic muscles of eyes are supplied by the mm, oculomotor nerve except superior oblique and lateral rectus. So its palsy would result in down and out eye movement. Charcot-Bouchard aneurysm. It is common associated with chronic hypertension. We have seen it previously. Defect in small vessels, for example, lenticulostriate arteries in the basal ganglia thalamus, and can cause hemorrhagic intraparenchymal stroke not visible on angiography. Fever versus heat stroke. So, what is pathophysiology? As in fever, we have inflammation, and as a result of inflammation, there is cytokine activation. This cytokine activation would increase the temperature of our body, resulting in fever. And what happens in heat stroke? It is an ability of body to dissipate heat. For example, we have heat in our body, but this heat is not dissipated, is not transmitted to the environment from our body. So this will at last raise our body temperature. The temperature is, for example, or up to 104 degree Fahrenheit, and in heat stroke it is more than 104 degree Fahrenheit. Complication, there would be febrile seizures as a result of increased temperature, benign, usually self-limiting. It is due to CNS dysfunction, confusion. It may result in CNS dysfunction like confusion, rhabdomyolysis, acute kidney injury, ARDS, DIC. How can we manage fever? Very simple. We can give acetaminophen or ibuprofen for comfort. Does not prevent future febrile seizures. Antibiotic therapy, if indicated, we can give. You can also give antibiotics. But here in heat stroke, there is rapid external cooling, rehydration, and electrolyte correction. What are seizures? These are characterized by synchronized high frequency neuronal firings, and there are a variety of this. These may be focal seizures involving only some part of our body, generalized seizures in which our whole body may have seizures. So what are focal seizures? Affect single area of brain, most commonly originate in the medial temporal lobe. This is the important thing. So types. Focal waves, formerly called simple partial seizures, consciousness intact, motor, sensory, autonomic, psychic. In this, consciousness is intact, but patient may have motor seizure, sensory symptoms, autonomic or psychic symptoms. This occur in epilepsy disorder of recurrent unprovoked seizures. Febrile seizures are not the epilepsy. Status epilepticus continues for more than 5 minutes or recurring seizures without interictal turn return to baseline condition that may result in the brain injury. So you should keep it in mind. It is a very important viva question also if you are preparing for viva for some exam, and very important in the USMLE part 1 exam too. Generalized seizure, diffuse, involving whole body. It has multiple types like absence seizure, petit mal seizure, 3 Hz spike and wave discharge, short, usually less than 10 seconds, and frequent episodes of blank stare. Most of the time, parents come with a child and they complain that our child is continuously looking at the floor or some space. So it is there is no post-ictal confusion, or you can say no confusion after the seizure settle can be triggered by hyperventilation. This may be the result of trauma, congenital, metabolic, adults 18 to 65, tumor, trauma, stroke, infection, adults greater than 65, stroke, tumor, trauma, metabolic, or infection. The next one is myoclonic. It is quick, repetitive jerks, no loss of consciousness. Tonic clonic. Tonic means the patient would have at the same time increased tone of their muscles and at the other time relaxation. So grand mal, alternating stiffening and movement. Post ictal confusion is present. There is urinary incontinence or tongue might be present. So it is an important thing to remember. Tonic is stiffness. Atonic means drop in stiffness or drop seizures. Fall to the floor, commonly mistaken for fainting. So it is not fainting. So seizures, focal seizures, which have wave, focal aware and focal impaired awareness, and it is secondary generalized. It means it may progress to generalized, which is then secondary generalized. And other type of seizure is generalized seizures, which are tonic, stiffening, myoclonic, quick and repetitive jerks, atonic, drop seizures, fall to the ground, absence, petit mal, blank stare, no post-ictal confusion. So, tonic-clonic, grand mal, alternating stiffening and movement. Okay. The next one is headache, very important OPD complaint, especially in females. We also have female enemy here and this male. Okay, what I have done. So, yes, headache, pain due to irritation of intra or extracranial structures, e.g., meninges, blood vessels. Primary headache include tension type, migraine, cluster. Secondary headache include medication induced or overuse, meningitis, subarachnoid hemorrhage, hydrocephalus, neoplasia, joint cell arteritis. So tension type, localization, it is bilateral. Duration, it may remain more than 30 minutes and typically 4 to 6 hours. It is constant in nature. Description, it is steady, constant band like pain, no nausea or vomiting, no more than one of photophobia or phonophobia. No aura present, most common primary headache. More common in females. Yes, as we have a female DP, so it is common in females. Treatment occur. Acute cases can be treated by the analgesics like NSAIDs, acetaminophen. In prophylaxis, we can give tricyclic antidepressants or amitriptyline behavioral therapies. So migraine headache is unilateral. It may remain for 4 to 72 hours. Pulsating pain with nausea, photophobia and or phonophobia. May have aura due to irritation of cranial nerve 5, meninges or blood vessel. Cranial nerve 5 is important. Vessels of vasoactive neuropeptide substance P, calcitonin gene related peptides, more common in females. So acute cases can be treated with NSAIDs, triptan, dihydroergotamine, antiemetics, prochlorperazine, metoclopramide. Prophylaxis can be given as lifestyle change, sleep, exercise, diet, beta blockers, amitriptyline, topiramate, valproate, botulinum toxin, anti-CGRP, monoclonal antibody. So cluster headache. Oh, sorry. So cluster headache. Hmm. What is going on, man? Yes, cluster headache. It is unilateral and may remain for 15 to 3 hours. It is repetitive, excruciating periorbital pain, suicide headache with autonomic symptoms, e.g., lacrimation, rhinorrhea. Conjunctival injections may present with Horner syndrome, more common in males. Acute cases can be treated with sumatriptan, 100% oxygen prophylaxis as a result can be given with verapamil, which is a calcium channel blocker. So the next thing is trigeminal neuralgia. It is recurrent brief episode of intense unilateral pain in cranial nerve 5 distribution, usually second and third branch. Most common are due to compression of cranial nerve 5 root by an aberrant vascular loop. Pain is described as electric shock like or stabbing and usually lasts seconds. So most cases are due to compression of cranial nerve 5 root by an aberrant vascular loop. Pain is described as an electric shock like or stabbing and usually lasts seconds, typically triggered by light facial touch or facial movement, chewing and talking. Treatment is carbamazepine or oxcarbazepine. So the important thing which is to remember in case of trigeminal neuralgia is the distribution of nerve by which we have this kind of pain. The cause, the pathophysiology, which is the compression of cranial nerve 5 root by an aberrant vascular loop, and its treatment, which is carbamazepine and oxcarbazepine. Okay.